And we are now live. So hello everyone and welcome to another DentalShadowers virtual shadowing session. Today we are joined by Dr. James, who is an oral and maxillofacial surgeon. Thank you so much for joining us, Dr. James, and whenever you're ready, you can take it away.
Okay. Hi, everyone. Thank you so much for this opportunity to show a few cases to you guys to kind of let you into my world virtually, to show you some things that we do as far as in a private practice setting of an oral and maxillofacial surgery office. I'm going to talk to you a little bit about, what I do, my ownership. We're going to talk a little bit about some case studies or some cases that I'm going to show you guys a little bit about me. I'm Dr. Portia James, oral and maxillofacial surgeon. I am a graduate. I'm from Dallas, Texas. Currently reside in Frisco, Texas, which is a suburb north of Dallas. I graduated from Meharry Medical College School of Dentistry in 2008. I then actually went on to the Air Force as a general dentist. I did an AEGD during that time, a year, and I was stationed overseas for a couple of years in the UK and in England. And I applied to oral and maxillofacial surgery my final year of my 4-year tour. And I gained acceptance and I went back to Meharry Medical College, in which I did a 4-year oral and maxillofacial surgery residency in Nashville, Tennessee. So this is just me showing you and showing myself in the OR. So I'm going to talk to you a little bit about what we do and what I do. I am an owner of About Face Oral and Facial Surgery. After I finished my residency, I actually stayed on a year and taught oral surgery for Meharry with the dental students, as well as the residents. And I did part-time in a corporate sector as an oral surgeon for a company. So I know a little bit about the military side of things, the academic side of things, as well as corporate and private practice now. So like I stated, I'm the owner of About Face Oral and Facial Surgery in Frisco, Texas. It's called About Face because that is a military term. I'm a U.S. veteran. And so About Face means to turn things around. So that's what we do in our office. We turn things around so that we can transition lives and people's livelihoods. So I'm a mom. After I graduated from residency, and I was married in residency, but I have a daughter. She's now 3 years old. As a practice owner, especially as a mom, as a surgeon, I hold a lot of hats. So when I started my practice, or when I was renovating or reconstructing our practice, I was very pregnant. We had moved from Tennessee. Moved to Texas. So we moved to a different state. I was about 5 months pregnant at the time, getting everything started. I had to have when I had my baby, and when we finally opened, when I was interviewing for positions for my assistants, my baby was 5 weeks old. So I had to you adapt. You have to move forward because you have to pay bills. So I had my baby in the office with me for the first 6 months during this time frame. So yeah, so that's what you got to do as a surgeon and a mom, because you're still a doctor. So I already mentioned kind of my background. Oh, I didn't mention my undergrad. I did go to Xavier University of Louisiana. So these are things that oral and maxillofacial surgeons do: wisdom teeth, implants, extractions, head and neck pathologies, as far as head and neck surgeries and reconstructions, jaw surgeries such as orthognathics, which we work with orthodontists for. We do TMJ surgeries, or in oral facial pain. We treat sleep apnea surgically. Also do facial injuries, facial trauma, cosmetics, cleft lip and palate anesthesia. The bread and butter of most oral surgeons will be, in the private practice, is going to be a lot of extractions, complex implants, pathology cases, like when doing biopsies. And anesthesia is a major part of what we do, because most people, when they see us, they're so scared. So they don't want to be awake for a lot of things that we do. So these are things that you need to do to get into OMFS. You have to, of course, be a dental student. In your 4th year, usually you're going to apply. You have to do PASS. You have to have a CV. You need to get a good personal statement, transcript, diploma. You need 3 good letters of recommendation. Notice I put good in all caps because you want to make sure that you have a good relationship to the person that you're asking for a recommendation from, to ensure, that you're going to get a good letter, not just stating that this person was a student here from this date to this date. That's not a good letter. Also, a letter from your dean, transcripts. The board now is much different. It's now pass and pass fail, for as opposed to when I applied. I was kind of like one of those last classes that didn't have to take the CBSC exam, so I got in there right on time. So now you have to take that exam. It's a medical exam. So you have to do very well on that. Speaking to other programs that are program directors of OMFS programs, they typically state that now they want you to have approximately about an 80 or so score to do very well and to increase your chances of gaining acceptance. Of course, you also need to do externships, as many as you can. So that's very, very important to do externships. And I know if you go to the ADIA website, you can find various residency programs, and a lot of times the residency programs will have externships. But so before we get into that, one thing that I will tell dental students that are interested in OMFS is that if you are at a dental school that has an oral surgery residency there, you need to be in that clinic as much as possible. Whenever you get a patient that doesn't show up for their appointment, or you don't have anything to do, instead of just leaving for the day, go to oral surgery. We always got something going on. And if you build a good relationship with the residents, sometimes they'll let you go to the emergency room with them, or they might even let you go to the operating room, depending on that program or the stipulations that they have. So it's always great to show interest early on, so that you're able to build that relationship with the residencies. So a lot of people ask, what's the difference between a 4-year and a 6-year program? As far as qualifications, what we can do after residency, it's still the same. The difference is a 6-year program, you will get a medical degree. So how is that more advantageous? So it means that if you know that you're interested in doing a subspecialty outside after residency, like facial cosmetics, or if you want to go into like a head and neck surgery program that's heavy with cancer, your chances to gain acceptance are a little bit greater because you have your medical degree behind you. Actually, some people even go on to do full body cosmetics afterwards, which could be a 2 or 3 year fellowship after, oral and maxillofacial surgery. So that means breast implants, Brazilian butt lifts, all of those things. So, and that's what you can do as far as what the program will allow you to do and what your training is essentially. So these are things that I do in my office: extractions, implants, bone grafting, sinus lift, pre-prosthetic surgery, biopsies. I do a lot of facial rejuvenation, so cosmetics kind of things. You don't really get too much trauma in a private practice setting, but I still do have my hospital privileges at Texas Health Presbyterian. So if I'm doing a hospital case, that's where it would be done. But we're going to talk about stuff that I'm doing in the office. So just quickly, when I go over a couple cases, I'm just going to keep it simple with implantology because I feel like at this point, you guys have probably talked to various specialties that are placing implants now. So I'm just going to keep it simple. We had a patient that came in, with a missing, he had previously gotten extracted number 30. And they bone grafted for ridge preservation for a future implant. Generally we'll let that bone graft heal for about 2 or 3 months or so before we place the implant. So this was what the site looked like after the extraction, after a few months of healing from the extraction and bone graft. Looks good. We placed a single implant over there, kept it simple, nice wide implant, no nerve damage or anything. That implant will heal about 3 or 4 months. Then I put the abutment on, which is what you see at the top. So I went ahead and put the healing abutment on in one appointment, so he doesn't have to go through an additional surgery because the bone was very good quality. And so, he'll see his general dentist and after that has healed, and they'll put a crown on there. So keep it simple with what we did. So this is just another implant case that I did. Edentulous lower left ridge. These were actually, I didn't do this guided at all. I think that's an advantage that we have as oral surgeons, is that we get a lot of training in implants. I know for us, we got a lot of implant training at the VA. So, that was really great for the veterans because they didn't have to pay for it. It was covered. And so, and as the residents, we got a lot of experience in placing implants. So I got very, very good at it. So just keeping it simple with what we're doing. Those are the implants that are going into that ridge. Usually you'll have to flap it, and full thickness mucoperiosteal flap, gain access to that entire ridge there. You want to have really good parallelism in your implants, especially when you're doing multiple implants. So you can see everything looks great, crisp, clean. Implants going in, implants seated all the way. You see the 3 implants that we placed there, sutured, continuous suture, looks great, healed great. A lot of cases that we will do, I'm actually next door to an orthodontist, so I get a lot of these cases, and you guys you're gonna find out about like the most common impacted teeth. Their wisdom teeth are pretty common, but also canines are very common too. So we get a lot of exposure and bond cases. So basically what an exposure and bond is we gain access to that tooth that is impacted. Usually it will be a canine tooth. So we want to gain access to it so that we can apply this eruption appliance to the tooth, to the crown of the tooth, or a gold chain, as we'll just kind of call it in simple terms. So the whole point of the chain is that every time that they see their orthodontist, they're gonna activate that chain, which the chain will help to bring the tooth down. So got a couple cases that I'm going to show you guys today. This is a case where we're at number 11. You can see that she's missing it. You can't see it. So we're going to find out where that tooth is. And if you look at number 10 on this particular patient, you'll notice that 10 looks like it's flared. It's kind of flared outwards. And the reason why is because that canine is sitting on top of it like that. So that's why. So now we're going to gain access to this canine. We're going to put a little button on this canine, and we're going to attach the chain to the wire. And we're going to close this up and allow it to kind of her to see the orthodontist to continue bringing that tooth on down. So the surgeon's job is to gain access to the tooth and to apply the eruption appliance to help facilitate that movement of that tooth. This was a young people. Young people are ideal candidates for this, especially teenagers. It's kind of harder to move the teeth as you get a little bit older. So we like to do them when they're young, because the bone is so much flexible. And so it was kind of like the same type of situation. I think I did I extracted a primary canine on this patient too. That's why you see that little socket there. And then I gained access to that number 11. Again, this is a different patient. And so kind of the same situation. The gain access to it, control the bleeding. That is the hardest thing about these cases, is that, we're doing surgery. So it's kind of like the same thing as when you're doing composite, when you're doing operative. So we etch it, we bond it, and we have to apply the chain on that. So this is a resin that we're applying. So, you have to keep it dry and you have to keep the blood off of it. So a lot of times we'll use different things to try to keep the blood down, but it's still always hard to keep this field clean and dry. So, but yeah, so this is what I'm doing. I'm applying this chain. I think they ended up, I forgot why their wires weren't on that day, but typically we would like them to be in there, have the wires on so that we can attach it to the wires. Final case. So this kid was a little bit older. I want to say this kid was like 15. So he's been walking around like that all this time. And as you can see, they have a baby canine over there. They have a missing number 9 that you can't see. The number 9 was impacted, and that number 6 was impacted. So, I felt kind of bad for the kid to be walking around like that for so many years, without those teeth being erupted and exposed. That will be a damper your confidence. You're a teenager in high school, without your front tooth. So, that was pretty hard. But yeah, we exposed those, gained access to them, and basically did the same thing. So we're going to put chains on both of those to help facilitate and bring those teeth down. And these things tend to take about give or take 6 months. It depends on the patient. They have to still make their appointments and things like that. If they don't go to their orthodontic appointments, that will delay things quite a bit. So we always encourage them to make sure that they keep their appointments. Going to move on to some pre-prosthetic surgery. This is a patient that had bilateral mandibular tori. As if you guys know, tori is one of those things that you don't necessarily have to do anything for just because you have it. It's a variation of normal. So that means that if you had it and you don't have to get a denture or anything, you can keep it for the rest of your life. But in this case, this person lost their teeth, so they're not going to be able to adequately fit a denture. So we got to remove that tori or reduce the tori size. You can see they're pretty big. So in this case, I'm going to do a full thickness mucoperiosteal flap. I'm going to reflect the lingual quite a bit to gain access. You make sure that in these cases, you have a very good and trained assistant, because what you don't want is them to slip the retractor and risk you tearing the floor of the mouth up, because that's always horrible for the patient, because it takes quite a bit of time for that to mucosalize and for that to heal, and it's just open and exposed bone, and they're not happy with you. The patient is not very happy, especially if they're a smoker. It's going to take forever for that to close. So I just generally will trough, and you kind of get a chisel and you just chisel that stuff away, and then smooth everything out. So you can see on both sides, be smooth as a baby's bottom once you smooth everything out. So that's the final result. Suture everything back together, and allow them to heal, and that tissue on that lingual side, that will shrink and heal nice and pink to get them ready for a denture. So this is a different patient, but same kind of situation. In this case, he has buccal exostoses, and I think they had tori too, but I'm just showing a picture of once I flapped everything and reflected to gain access to the bone. You can see that lateral exostoses there. And basically we're going to smooth that down with a big burr. I usually use like a big oval burr to just reduce that down. And then you take a bone file and kind of smooth that down afterwards, and just irrigate any kind of bone dust that you have. And this is the same patient. They also had tori. So I did the same thing to reduce that tori as well. And so that's the final result, although the pictures aren't that great, but you can get the gist of what we did. So everything, arch is very nice. Everything is very smooth, and the patient's good and can get a good denture. I'm going to show a quick this is small. I don't know if anybody's in the office, but this kid was autistic. That's why the hygiene isn't that great here, but he had a little bump on his lip. And so we just removed it in the clinic. And he did a great job. So I was very proud of him that day. And so this was the bottom right. I think it ended up being just like a mucocele. Remove it, and then the bottom is him healing from that. I see a lot of mucocele in my office because I also have a pediatric dentist, and so a lot of them are kids that get these little mucocele, and so we remove them. And usually I'll just give them like nitrous, and it's a quick appointment for me because we try to get in and get out of there. So that's why it's super important to have really, really good and trained assistants that you're working with. I'm going to show a cosmetic case. So this kid came in. This is a recent procedure that I did. Actually, I think I did a couple weeks ago. Actually, I took his wisdom teeth out. But during this consultation, I was just talking to him. I was like, I noticed you got this big keloid on your ear. How long have you had that on your ear? He's like, oh, I've had it about a year or so. I had gotten an ear piercing and, it got infected and it just kind of healed this way. And it's been growing for like over the last year or so. So I asked him, I said, well, do you want to get it removed? I can remove that for you. And he's like, yeah, So he came back and we did what we needed to do to take this out. Let me unshare for a minute. I wonder if I can show you guys this. I was trying, well, I don't think I'm gonna be able to do it. So I'm not even aware. I did a video, but I could not put the darn video in the thing. So sorry guys. Give me one moment. But yeah, he was like, yeah, I want to get it removed. Do you mind? He said, yeah, I want to get it there. Cause I mean, it just messed up his confidence. And, he was just like, I don't want that to be there. So, yeah. So as you can, when I was doing his surgery, in my mind, I had what I wanted to do for him. However, you can see how big this keloid is. I thought it was going to be as simple as kind of, removing it and kind of excising this, and then I can use some of that skin to close it up. But this thing, I mean, it was nothing but keloid. All the skin was keloid. I said, man, this was not what I thought was going to be my final product. So this is what his ear looked like once I finally got that keloid off, because all that skin, a keloid is basically a scar tissue that accumulates. It's very common in people that are of darker skin complexion. So that some people are very, very prone to getting keloids. So he was just unfortunate that he got one. But once I removed it, this is what it looked like. I always say it looked like we gave him the Mike Tyson ear. I don't know if y'all are old enough to remember that fight, Mike Tyson and Holyfield, but he took a bite out of his ear. So this is what it looked like after I removed it. As you can see, it's about 2 centimeters or so big. So that's pretty big for an ear. But this was what we did. I finally got it. I reapproximated everything. So he looks really good after. This was immediately after. So I also put him on a steroid protocol so you can kind of see where he started versus, where he ends, and it's only going to heal better. And I'm such a perfectionist, so I'm really not satisfied with how this ear, finally looked, because that wasn't the plan for me in my head. But sometimes you have to work with what you have. In his case, that earlobe was basically just keloid, but the patient loved the results. He was so happy because he got this keloid out. And when he went back to work, he was like, man, everybody was like, your surgeon did a good job. I need to refer, my friend to them or something. And I was like, okay, because I'm like, you have such high expectations for yourself. And you're like, man, I could have done this, I could have done that. But at the end of the day, the patient was very satisfied. Confidence went through the roof. He was like, it was like hard for his dating life because, people see this big keloid. So yeah, he looked so good afterwards. I'm going to show you guys a case called an oral antral fistula. So these things happen after extraction, that may have been very, very close to the sinus cap, maxillary sinus, or maybe even in the sinus. This is a before picture. I didn't do the extractions. This patient was referred to me after the fistula had already formed, but I got their x-rays preoperatively. If you look at that number 2, you can see how the sinuses are very, very low. So once that tooth comes out, the sinus is open. So a lot of times I will tell you, if you don't know how to do adequate closure, you need to just refer that to oral surgery, because we're probably going to have to, it's not going to be as simple as just an extraction. The extraction itself will be super easy because this person has bone loss. The tooth is probably kind of loose. So when you look at it, you're like, oh, I'll get that tooth out, no problem. Bam, it's easy. But you got to remember, the only thing that's blocking that sinus is that tooth. So once that tooth comes out, it's open and it's exposed. So this was after, I think this is what they looked like when I saw them. So that sinus cavity is basically open and exposed. The patient had been complaining of just chronic, just congestion. She was having like a really foul odor and discharge that was draining through. Kept complaining, like when she drank liquids and things like that, it would come out of her nose. So she was also a smoker. So you can kind of see that little clefting that's right there, that little divot, that little defect that's in the gum. So that was open. And that's why I wish I could show you some videos, because I had done some videos of her where I had her like blow and you'll see pus draining out. That's called, you're doing a Valsalva maneuver where you have to do this and blow, and stuff was just oozing out. I mean, she had pus just draining out. And I said, oh my goodness. So once I opened everything up, I don't know if you see the picture on the right, you see that hole that's there. I hadn't removed bone or anything. That's just what it looked like once I opened it. So as you can see, where that hole is or where that defect is, that's where the whole root of the tooth was. So like I said, once the tooth is gone, that's just open and exposed. So she had so many, like I just put my suction in there and we were just sucking out all kind of polyps, nasal polyps and all this stuff. It just, because it had been open to food and debris had been kind of getting in there. Her sinuses were just, it was just really infected. So cleaned all that out. What I ended up having to do is called a buccal fat pad rotational flap. So what you see there is cheek fat. So I had to basically, once I cleaned it out very well, I had to get her cheek fat to bring it over that hole. The cheek fat is really, really great. You don't take it off. We're just pulling on it. We tug it. We're not removing it. We're just tugging it. And then I'm going to do a layered closure in that area to basically close that hole or plug that hole in to allow for this to actually close. And you do this in multiple layers. So close it up, and then this is the final result once we close that up. And she ended up finally healing. The thing that you want to tell patients though is that they're going to swell up like they got into a fight. And that's because the cheek fat that we're pulling on and we're tugging on. Like I said, in this particular patient, she was a chronic smoker. So it took forever for this thing to heal. I mean, she just would not stop. And I had to tell her, I said, look, I don't want to do this surgery again, because the surgery was very successful. I did what I needed to do in order to get this thing closed, but you have got to stop smoking so that you can have your final healing. So we finally got her to stop smoking and she finally healed. But that's how you look like maybe 3 or 4 days afterwards, they're going to swell up quite a bit. And so she was like, man, I am swollen. I said, I told you, you're going to swell quite a bit. So, and that's actually the kind of the same procedure that I do in the office, kind of for a cosmetic case. I'll do the same thing. It's called buccal lipectomy, or removing or buccal fat pad reduction. Some people want like a more sculpted face. And so sometimes we can do it with local anesthesia, or some people want to be asleep if they have a lot of anxiety, but we remove that fat. We were actually remove it this time. Take it out so that their cheeks can be slimmer and more sculpted like that. So, but yeah, so that's the same things you do. Just going to show a couple trauma cases. Okay, we're doing good on time. So this is some stuff that you'll see in either when you see this guy on the right, you look at the right side, you'll be like, oh, that's not too bad. You're okay. And, we can do a couple stitches. But then when you open them up, you're like, oh, okay. I wasn't expecting that. But all right. I think he had just missed the superior labial artery up there. So but we got it. And as you can see, what you see in the lid, that is a bicularis muscle. So yeah, your lip muscle basically is what was split open. So you have to clean these folks, clean their mouth up very, very well, irrigate. Maybe you can irrigate with even chlorhexidine, numb them very well. And this is our emergency room patient. So, I just usually give them local anesthesia, or sometimes I might give them a little sedation depending on what's going on, or if they've been, if they're just too obnoxious because they've been drinking and they got in a bar fight and that's why they sustained this trauma or whatever. I can't remember anymore what was going on, but I think I want to say I was able to do him with local. So you have to, do multiple layer closure because you have to get that muscle back intact. And then you basically suture from inside to outside. So final result, it looked pretty good once you close all of that up. Probably gonna have a little bit of scarring on the skin, but if patients follow up like they're supposed to, you can put them on like a scar protocol. Like these days, I like to do silicone sheets on the skin. I will have them come back, about every month, basically, to do these steroid injections to try to help prevent keloiding and things like that. This is another guy. I want to say it was something sharp. I think it was like a punch that kind of grazed him down, like somebody had a ring on or something that caused that to kind of graze down. But yeah, so the same situation, you irrigate very well, clean very well, numb them. You got to be very careful when you're numbing the nose, especially because it's an in organ. So nose, ears, things like that, you try not to use too much epinephrine, because remember, epinephrine is a vasoconstrictor, which means that it's constricting blood vessels. So if you're constricting blood vessels on an in organ, then sometimes that can cause some necrosis or skin necrosis. So you have to be very, very careful with those things. So this was a clean cut. So actually clean cuts are good because that makes your reapproximation easier. So suture him up and he looked great. And he's going to heal very well too. Okay, look at me. I did good this time.
That was amazing, Dr. James.
Too much, and I end up being about an hour or so. So I was trying my best not to bore you guys too much, but show you some really cool, quick little cases and things like that. So this is the time to answer any kind of questions that people might have.
Awesome. Thank you so much. We do have a few questions in the chat. So our first question is, how often do you encounter complications? What was the worst complication?
I'm trying to think. I guess complications, it depends on what I'm doing. Like, let's say, for example, if it's like an implant complication, I don't get too many, knock on wood, but sometimes you do. And honestly, implant, I guess for me, is kind of easy because in that case, we're going to take the implant out, bone graft it, let that heal, and basically kind of start all over. Skin stuff is where the complications can get kind of bad. Especially when they get infections and things like that. I'm thinking about, a case that I did a mandible fracture with it was a homeless woman that we did a jaw fracture with. And she because she was homeless, she wasn't really she just wasn't keeping herself clean because she's homeless. They shower whenever they can and things like that. So I remember her suture site, she just did not come back for us to remove those sutures. The suture site kind of split open and it got infected. So I ended up having to do a skin graft for her. I think we did like a shoulder graft, did the skin graft, and then I ended up having to put her, we had to put her in the hospital, had to do like a wound vac on her to allow for that to heal. And it's honestly because we ended up keeping her because we wanted to keep an eye on her because you just didn't know when we were going to see her again, and I don't know if this is going to get worse, but she actually ended up doing very well after it was all said and done. It was like a big story about her because she left and moved back to like some other state and then came back. And so when we see her months later, she had this infection and we're like, what in the world happened? But those are kind of some things that, luckily that's the thing about, oral surgery is that we're trained on treating complications and managing complications. But sometimes the patient has to help you too. If you don't come in, how am I going to know? And so that's the only thing that tends to happen a lot is you get lost to follow up with some of these cases, especially in residency, because a lot of times it's trauma related because they were drinking or something like that. And so, they might go to jail they might be homeless. Like I said, it's just so many different things. But yeah, that's one that I can remember pretty well, just because we finally saw her, it was like bad. So we're like, oh my gosh.
How was your experience attending Meharry College?
Okay. It was good. You know, I had really good classmates that I still keep in touch with to this day. Meharry Medical College is a HBCU. So you know, it is, which means it's a historically Black collegiate university. So I actually have gone to two. So I was already familiar with how that environment goes. So it was a great experience for me. It was it's a small school. It's a small private school considering other like public dental schools. I think our particular class, we graduated with 48 students. So it's not a super big school. So we do have a very family oriented type of connection that we tend to have. So that is always a plus. You know, I didn't feel like I was a number there. You know, I felt like I really knew, you know, my professors. I knew the dean, I knew the associate dean. So you really know these people. And it's not just when you're walking by the hall, they'll be like, you know, hey, Portia or whatever. And you're like, oh, you know my name? Oh, really? Okay. Or something like that. So that's definitely something I can say I had a great experience. Clearly I did. I went back to do my residency.
Can oral and maxillofacial surgeons work in the emergency room? Do hospitals often have an oral and maxillofacial surgeon in general?
We don't work in the ER. So what happens is we're on call, meaning that, and depending on the program that you're in, let's say if you're a resident, so if you have a residency program, they will call you for, you know, someone that has sustained something on the head and neck or whatnot. So they'll call you to come in to see the patient, assess them, treat them if necessary, if you can treat them there. If it's something that, you know, that's a little bit more advanced and you got to admit the patient, then we will admit the patient and schedule them for the operating room for surgery, either, you know, that night or the next day, or we try to schedule them pretty soon, depending on what's going on, because if we're admitting them and then something needs to be done. But it's not like you're going to be on the emergency room staff.
Okay, that makes sense. Did your residency for OMFS consist of long hours as well as overnight shifts?
Yes. It's always going to be any surgical residency that you do, it's going to be long hours. The one thing that I will say about my program for residency is that there was only, they only accepted one per year. So we had a small program, which means that I would be on call for like a week at a time. And depending on who was on service, you know, I might be on call one week, then the second resident's on call the next week, then I'm back on call that third week. So, you know, that's kind of how we have to flip it back and forth like that. So it's it can be very tiring. You're not going to get a whole bunch of sleep. And I always used to joke that I had my baby like, you know, about a year or so, almost 2 years after residency. So I was like, I'm already used to a messed up sleep schedule at this point. So this isn't going to be new for me to have to adjust to getting up at, you know, odd hours of the night. But like literally, if I'm on call, if I'm on call and I have to go to the emergency room for whatever reason, 2 or 3 o'clock in the morning, you still have clinic patients that next day at, you know, 8 a.m. or whatever time you start clinic. So you really can't use that excuse. Oh man, I was on call last night. I didn't get any sleep. No, we still got patients to see. So
that's true. What limitations in practicing do you think there are for an OMFS?
None. I don't know. You know, we're, as a specialist, you're limited to what, you know, you're trained as far as in your specialty. So I guess I'm not quite sure of what they're asking for in that, but if they want to clarify. But I mean, as far as what I do, it's really no limitations as far as what I can do, as long as I feel competent in doing that procedure, and I'm not doing any malpractice.
What are nasal polyps?
So nasal polyps, they're kind of like the, they look kind of like these little squishy mucus accumulations of mucus. They feel like putty, I guess. It's kind of solid, but kind of mucusy. Is that what you'll get? Yeah. I guess that's the best way I can explain it.
Do you regret any decisions you made while on your dental journey? Would you have changed anything if you had the opportunity to do so?
One thing that I think I would have liked to do is I wish I would have gone straight to residency. Because I don't know if you guys were listening, but I did a 4-year tour in the Air Force. And honestly, my Air Force time kind of reaffirmed. I always knew I kind of wanted to do oral surgery, but by the time I was done with dental school, I kind of got to that point where it's like, I'm not doing anything else. I'm just gonna, be a dentist and, go do my 9 to 5 and go home. But my situation was very unique in the Air Force, especially when I was stationed in England. So when I was in England, that particular base was designated for 2 oral surgeons. But at the time, there was a shortage of oral surgeons at that particular moment in the Air Force. So I was actually, because they knew I had an interest in it, they allowed me to have like 2 days of just oral surgery. So in my clinic, I would, do my extractions, wisdom teeth. I had learned how to do wisdom teeth at the time. And I would also be able to go to the operating room with the oral surgeon when he was scheduled to go to the operating room. So that was a very unique experience for me that probably no one else has gotten. So I was very thankful to be allowed that opportunity, because it was almost like, I was kind of doing like an internship or a fellowship during my 2 years that I was overseas there. And believe it or not, that experience, because I was able to do like orthodontic case, assist on those cases, orthodontics or any kind of trauma, if he got any trauma in the operating room. So, that was an experience unlike any other. So that to me afforded me the opportunity to gain gain acceptance into my residency program because of my background.
What made you choose oral surgery as opposed to any other specialty?
Because it's the most fun. Come on. We do trauma, we do cosmetics, Botox, fillers. I could do chin liposuction. I can do a facelift if I wanted to. I just love the variety that it has. I love the fact that it is that bridge between medicine and dentistry, because some of the things that we do are so far from dentistry a lot of times. And so I just love to be able to do so many different things, where I feel like, if I'm doing a cosmetic case, which is things that I really enjoy doing, I feel like I'm able to transit, to basically make someone more beautiful, or, help them improve upon something that, they had been feeling bad about on themselves. For example, the kid with the keloid, that was like a life-changing thing for him. It only took like an hour, but that was life-changing for him.
What kind of personality do you have to be an OMFS?
Probably like, you'll probably never meet another surgeon like me. I'm very, I'm kind of laid back. Like even in the surgery, I'm not going to throw instruments. I'm not going to talk crazy to you. I expect you to do your job, but I think that I'm more of a very relaxed. I think surgeons tend to be very kind of, I don't know. I don't know how to say it. It tends to be, I don't want to say aggressive, but typically they're kind of more stern about things, or typically. But I think for me, my personality, I think a lot of people were surprised that I went into OMFS, because I'm a quote girly girl. So, that's not common. OMFS is typically a white male dominated specialty, as dentistry is, believe it or not. So, for me to be, it's really like 2% or less of African American females that are oral and maxillofacial surgeons. So I'm really a unicorn in this specialty. So, but I love it. And, I really want to encourage more women to get into this field. So, as far as we're changing how people see us and what we're doing. But the thing is, at the end of the day, I have the skill, the surgical skills and the knowledge as anyone else. So knowledge can never be taken from you. Your skills can never be taken from you. So yeah.
That's very true. What's the thought process for choosing implant sizes as well as choosing bone level or tissue level implants, or is it just preference?
No. So when you're planning for implants, you're looking at the bone quality, how much bone is there. You're looking at, if you're doing an upper implant, where's the sinus? Am I going to do an implant that's too long, that's in the sinus? For the lower jaw, you're going to look at where your nerves are. You don't want to put an implant in that's going to be too long, and then you're in the inferior alveolar nerve or the mental nerve, and now this patient is numb forever. So it's when we're planning things, especially nowadays, we do cone beam CT scans so that we can track exactly where the nerve is. And nowadays, digital dentistry is becoming very, very popular. So when you combine intraoral scanning with your cone beam CT, you're literally planning your implant cases digitally. So and even with our big cases, like with pathology cases, like if you're a cancer patient and you have to do like what's called a free fibula flap on the leg, and we're doing virtual surgical planning these days. So that way we know where any kind of vital structures are, but that is very, very important as far as planning your implants, and that will tell you the size, the width, and all of those things of the implant that you want to place in that area.
How competitive is it to get into an OMFS residency?
Very, very, very competitive. Traditionally speaking, most people are probably in like that top tier of their class. And honestly, that's why I say that these days now, they're really looking at that CBSC exam because they want to know that you're going to be able to handle academically the program, besides, the physical demands of the program, but academically, because a lot of stuff is very resident run. So it's really not a whole bunch of hand holding at all, because things tend to be very fast paced, and you need someone that's going to really be able to catch on. But is also going to read about various subjects that come in at the time, because sometimes you'll get a case and you're like, I don't know what to do. I've never heard of this. So you need to read about it before you present it to your chief of what's going on. So it's a lot it's not you don't get a syllabus. It's not like dental school. You don't get a syllabus and say, okay, hey, today we're going to be doing a lip laceration today. That's not how it works. So you don't know what you're going to be seeing. You don't know what you have in the hospital, what you're going to have on your service. So it's a lot of reading that's involved. So anytime you have downtime, which is rarely, but you need to be reading during that time. So that's why, a lot of times the people will be in the top probably 10% of their class.
Is OMFS what you thought it would be, or did you have like different expectations going into it?
Honestly, it ended up being more than what I thought it was going to be, because you really don't know what it is or what it really is going to be unless you know someone that's an oral surgeon. But as a dental student looking in, honestly, I thought it was just going to be like, of course, extractions, wisdom teeth, sedations, and orthognathics. But I guess I didn't realize, how vast the specialty is, and so how much so different from dentistry that it can be. I never thought I would be cutting on somebody's hip. I never thought I would be cutting on somebody's leg, or, getting fat from somebody's abdomen to do a graft somewhere. I didn't know that you did that prior to, becoming a resident. So yeah, it ended up being, a whole bunch more than what I thought it was going to be. Yeah.
Are there a lot of lectures in residency or is it more hands-on?
More hands-on there. Now there will be lectures. It depends on how your program kind of runs things. I know we would have a lecture every day for about an hour or two in the evenings. So it just kind of varies. And when I was on service for another hospital, actually they did their lectures in the morning. So it varies.
Do some OMFSs have an MD and DDS/DMD? How come
Yes.
some of them go to medical and dental school?
Yes. So, and that's what I spoke about initially, that is a 6-year program. If they get if they go to 2 years of medical school, in addition to the 4 years of oral and maxillofacial surgery residency.
Okay, but that's not required because instead you
No,
would.
it's different programs. So some programs are only 4 years, and then some programs will have a 4-year and a 6-year, or some might be only 6 years. So every program is different. That's why it's important to research the various programs that they have, and usually they will tell you. That's why I say if you go to the ADIA website, you will see the different programs.
Was it difficult to manage the business aspect of having your own practice as well as, being an OMFS?
It's always going to be hard. I'm very lucky in that regard, that my husband is a business and marketing major, so he handles the administrative side of the practice. I handle the clinical side, so it definitely helps to have someone that you can trust and that knows what they're doing, to have your back on that side.
That's true. What would you say to minorities that are applying to dental school or wanting to get into the OMFS residency?
Find a mentor. Find definitely, especially if you have someone local, find a mentor that can help guide you, especially if you're coming from a program that might not have a good pre-med program. I'm very lucky that I, graduated from Xavier University, Louisiana, because our pre-med program has always been phenomenal. For several years, we've been #1 into placing African Americans into medical school and dental school because of how they guide us. They start from the freshman year. But for those that might not have the best advantage, what I will say, typically, if you can get a mentor, but get you a CV, get you personal statement, start working on your personal statements for your application process, and go to your English department and see if they can, read over your personal statement for any kind of grammatical errors and things. You're going to need 3 science letters of recommendation. Of course, you're going to need to do well on your DAT. So make sure that you take the courses in preparation of that DAT. I think I did Kaplan back in the day to prepare for DAT. That's an important program to do. So, those are just with your letters of recommendation. Like I said, good letters of recommendation. Make sure that they would always train us to try to get science letters of recommendation when you're trying to go into dental school. So, but I know you also need to take your prerequisites, which is usually like calculus, organic chemistry, general chemistry, biology, physics. Y'all are taking me back now.
Yeah, physics is definitely on there, but it's not on the DAT, but you do have to take it.
Your prerequisite, yeah.
Yeah. What is something that you didn't know about opening your own practice that may have surprised you?
It's just hard. It's hard work. Patients are not going to come to you automatically. So, you have to get a network with insurances. You still might need to work somewhere else part-time. Because you're not going to be able to open 5 days a week initially. So you might want to open 3 and then work somewhere else 2 days a week or something like that. Just to make sure your bills are paid and things like that. So, you have to network, and you have to learn how to market and figure out what works for you. Because like I said, patients aren't just going to to come there. But if you need help, you're going to have to pay for help if you need to get a consultant or something like that. So that's the one thing that I will say. And make sure that you get your finances in order. Make sure you have a team, accountant, attorney, because you're gonna need that backing.
If you could change something about the practice of dentistry, what would it be?
That's a weird question. Let me think. I don't know. I don't know what I would necessarily change. I would change the dental school tuition, the student loan debt that we have, because I feel like nowadays, because tuition is constantly going up, and I feel so bad for the graduates of like 2020 and 2021 from dental school, because with all this COVID and things, I'm pretty sure, your clinical side of things, that's why we're doing this virtual stuff now, because everything dwindled. So, for you, having that clinical experience has diminished, but tuition is going up. That's just, it's a horrible situation. And especially if you're coming from somewhere where, you don't come from a family that has a dentist, that has a practice waiting on you for you to just join in with them. So now I would say, definitely do a residency afterwards, because you have to figure out how you're going to get that experience afterwards. Otherwise, you're going to be stuck in the corporate sector of things as a new graduate and being forced to join I always call them a dental mill. They love new graduates, but and honestly, you're kind of forced into those situations because you might have almost $500,000 in student loan debt. So yeah, that's something that I would definitely like to see change. Figure out what we're going to do about this student loan situation.
Yeah. What are some highlights about your workday?
Some highlights. I don't know. It just depends on what I'm doing that day. Because some days, like I always say, our busy days, like towards the end of the week, like Thursdays and Fridays, because a lot of people want to get surgery on Fridays. So Fridays, we try to just do nothing but surgery. We don't do consults, post-ops or anything. We just work. And then, I might order pizza for the staff or something like that because we're working hard. But we try to leave early. So that'll be the highlight of my day. If we can leave early and go get some good food. I know that's so sad, but sometimes that is what I look forward to. Like, oh, where are we going to go today, y'all?
Yeah. That's nice. Somebody asked, have you experienced any difficulty in the field as a woman of color?
Oh yeah. I mean, you're always get those microaggressions that you're gonna have, or a patient might not be very happy to see you because they weren't expecting you to look like that. So you might deal with, racism from patients, you might deal with racism from programs, especially if you're visiting somewhere or whatnot. They might not think that you're quite capable of doing things or doing certain procedures. So yeah, you're going to get that quite a bit. So it's very important to know your worth, know that you're fully capable, and be very confident about what you can do and what you know. And you have to prove them wrong, and you have to win at that. It's a game, unfortunately, but it's things that will make you stronger and will teach you how to respond if you're ever faced in that type of adversity again.
Thank you so much, Dr. James. That's all the questions we have for today, but we really appreciated your informative presentation.
Okay, thank you guys. I hope you guys enjoyed it.
Yeah.
Yes. Yes, I also want to thank you, Dr. James, and thank you to our audience for providing us with those questions. And we really appreciate you guys joining us. And until next week, when we have our next virtual shadowing session, I hope you all have a great rest of your week.
Okay. Thank you guys. Y'all have a great one.